All right, folks, welcome back to Discussions with Dr. G. Today we're diving headfirst into the drama that is hypertension. I know. Blood pressure talk sounds about as exciting as watching paint dry, but stick with me. This stuff can take people from feeling fine to the ICU in about as much time as it takes me to find my cat hiding in the laundry. So let's start with what hypertension actually is. Clinically, it's chronically elevated blood pressure. Think at least 130/80 on a consistent basis, not just one bad day like after Thanksgiving dinner or something. And you'd be amazed at how many folks are walking around with it and have no idea. It's a public health monster in the U.S. We're talking links to heart attacks, strokes, chronic kidney disease, retinopathy. Basically, unchecked hypertension is like setting your internal organs on a slow simmer and hoping nothing boils over. The pathophysiology is where things get a bit spicy. Most people have what's called primary or essential hypertension, which really just means we don't have a single direct cause. It's a combination of age, lifestyle, genes, maybe even a bad luck roll of the dice. Secondary hypertension is the one where we actually have culprits: kidney disease, weird hormones, sleep apnea. But on a deeper level, we're usually talking about overactivity of the sympathetic nervous system, which means higher heart rate, more contractility, and vasoconstriction, which is just a fancy term for squeezing those blood vessels tight. Throw in some endothelial dysfunction, less nitric oxide, stiffer arteries, and the kidneys deciding to hold on to every drop of sodium, and you've got the perfect storm. Separate but deadly. Hypertensive emergency versus urgency. And yeah, you've got to know the difference. An emergency means your BP has shot past 180/120 and there's actual organ damage happening. Maybe somebody's vision is going, or they're having chest pain or losing kidney function. That, my friends, is a straight to the ICU, IV meds, and no coffee break for the nurse. Now, urgency, same crazy numbers, but no organ damage. So you've got a bit of time, outpatient or urgent clinic stuff. Not quite grabbing the crash cart, but you still don't want to go to lunch. And wow, let me tell you about managing a hypertensive emergency in the ICU. I've had patients who swear if they eat some kale or whatever, their BP will magically return to earth, even with numbers over 200. Spoiler alert, a smoothie isn't fixing that, unless we're blending up some IV antihypertensives in it. Speaking of antihypertensives, let's go ahead and wade into that jungle. Fun times, right? These aren't your grandma's water pills. Well, actually, sometimes they literally are, but more on that later. Let's start big picture. 4 core med classes you'll see all the time. RAS inhibitors, that's RAAS inhibitors. Diuretics like thiazides, calcium channel blockers, and then, of course, various sympatholytics. Why do we have so many? Because hypertension is stubborn, and people are too. Top of the list, and the drama stars, ACE inhibitors, or the PRILs. Good news, they help with hypertension, heart failure, diabetic kidney disease, you name it. They lower vasoconstriction and slow down those kidney sodium hoarding habits. Bad news, the PRIL cough. If you've heard a patient hacking for no good reason, it's probably this. Oh, and angioedema when their airway decides to close shop on you? Yeah. Hyperkalemia and renal issues? Yeah, monitor those labs. Now we have ARBs, angiotensin receptor blockers. These are the sartans. These are your go-to if someone can't stop coughing because they're on ACEs. They work similarly, just less bradykinin, so way less cough, a little less angioedema risk, but you still need to watch potassium and the kidneys like a hawk. Aldosterone antagonists like spironolactone and eplerenone. These are your backup dancers. They help with resistant hypertension, heart failure after a heart attack, and so on. Plus, they block sodium and water retention while sparing potassium, sometimes a little too much. Overdo it, and suddenly you've got hyperkalemia and renal function tanking. Oh, and spironolactone can serve up some fun side effects like gynecomastia. Nothing says surprise like a little breast tissue in your male patients. Diuretics, look for thiazides. Classic first line, especially in black clients and older adults. They squeeze out the sodium and water through the kidneys. Hypokalemia is the common booby trap here, so teaching about potassium foods is going to be key. Get ready for dizziness, photosensitivity, and in the long haul, higher blood sugar or even gout. Calcium channel blockers split into two squads. The dipines, D-I-P-I-N-E-S, which just relax blood vessels, versus the non-DHPs, like verapamil and diltiazem, which also slow the heart. Watch for bradycardia, hypotension, and the weird side effect of constipation, especially in those non-DHPs. Tell your patients to avoid grapefruit juice. Trust me, it's not worth the pharmacokinetic chaos. Then we have vasodilators like hydralazine and nitroprusside. These are your heavy hitters for severe resistant cases or hypertensive crisis. Headaches, reflex tachycardia, and for hydralazine, weird things like lupus-like syndrome. Nitroprusside, you have to worry about cyanide toxicity, which is about as fun as it sounds. Now, let's not forget the world of beta blockers and sympatholytics. Beta blockers, or the OLOLs, great after a heart attack, in arrhythmias, and with heart failure. But please do not give the non-selective ones to someone with asthma unless you want to find yourself running both a code brown and a code blue. Alpha blockers like carvedilol, which mixes in both actions, and alpha-2 agonists like clonidine have their own quirks, like first dose syncope, bradycardia, rebound hypertension, and good old sedation. Nothing like a medication so relaxing that people forget they're supposed to monitor their blood pressure, right? Each class has its drama, which is why monitoring is king. Blood pressure, potassium, renal function, adverse effects. And remember, contraindications are everywhere, so you've got to know your patient's history, or you'll spend an exciting shift troubleshooting. All right, after wading through that pharmacological swamp, let's talk about what really matters: safety, and making sure your patients don't undo all the careful prescribing because someone on the internet said, you don't need pills if you drink celery juice. First rule, safety checks on every shift. Monitor for bradycardia, check those electrolytes, keep a sharp eye on kidney function, watch for red flags like sudden swelling, new cough, palpitations, confusion. If it's ACE inhibitors, you're going to look out for angioedema. With clonidine, did they stop taking it abruptly? Because you'd better believe that blood pressure is about to rebound faster than me when someone offers free donuts in the break room. Patient education is half the battle. Most folks feel fine with a high blood pressure, at least until things go sideways. Teach them to take their meds even when they think it's pointless. Monitor their blood pressure at home and avoid sudden stops on meds, especially like clonidine. Don't forget low sodium diets, exercise, cutting back on booze, and the smokes. You know, your usual suspects. Oh, and tell them to rise slowly. No one wants an accidental faceplant in the kitchen. Tell them the signs that mean they need help, like facial swelling, chest pain, and a persistent dry cough. Want a real-life story? I had one patient, sweet guy, but boy, did he think he was invincible. Got his blood pressure under control, then figured he was cured, so he quit his meds. Ended up right back in the ER. Blood pressure was in the stratosphere, and now every Sunday, like clockwork, he texts me a picture of his home blood pressure screen. I can't decide if it's superstition or appreciation. Maybe both. But hey, whatever works, if that keeps him adherent, I'll take it. Nursing comes down to vigilance, constant monitoring, early recognition of problems, and honestly, a lot of repeating yourself. Remind patients that not stopping their meds abruptly is a wise choice, not chasing potassium-laced salt substitutes if they're on ACE inhibitors, ARBs, or spironolactone, and know what red flags to look for. Support your patients, keep the education rolling, and if you're lucky, get a few Sunday texts. Just maybe not at 2 a.m. All right, guys, thanks for joining me. I'll see you next episode.